Hi, I'm Dr. Peterson with Regions EMS, and it's time for another Ebola update. This continues to be a dynamic situation with recommendations changing weekly from the CDC and the State Department of Health. We are committed to keeping you informed with the most current information in order to protect yourselves and provide appropriate care for our patients. As with previous updates, the information I will present in this video is current as of today, November 4th, 2014. Now, we still have several unanswered questions, but I can assure you that we are actively working to gather more information from the appropriate governmental agencies. Since the last update, we have released a viral hemorrhagic fever guideline, Guideline 79, to guide your response to a patient at high risk for infection with Ebola. Let's review this new guideline to highlight the important considerations that you should keep in mind. Now, there are three principles that should guide your decisions when responding to a possible Ebola infection. First of all, slow down. There's no reason to rush. Second, keep your exposure risks to a minimum. Minimize the personnel and the equipment exposure to the possibly infectious patient. And finally, gather as much relevant information as possible before making any decisions. Now, let's back up and start at the beginning. We are working with our affiliated dispatch centers to ensure that 911 callers with concerning symptoms are being screened for travel history or close contact with an infected individual and a fever. If both risk factors are present, this patient is referred to as a double positive patient and warrants the highest precautions by EMS providers. You should still be diligent and screen all appropriate patients for recent travel history and fever as the situation warrants, even if this information was not provided by dispatch. Now, currently there are only 3 West African countries we are concerned about: Guinea, Sierra Leone, and Liberia. Close contact with an asymptomatic individual who has recently traveled to one of these countries is not a risk factor, as infected individuals are not contagious until symptoms develop. And also, not everyone who travels to West Africa will be infected with Ebola. To put things in context, Africa is a very large continent which can easily contain the entire United States as well as several other large countries. Although it's important to remain diligent, there's no reason to be concerned about someone who has recently traveled to the greater Africa unless they have been to one of the 3 endemic countries. Now, if the patient does not meet the double positive criteria, they do not have Ebola, and you can continue to provide appropriate medical care using standard precautions. Once you have identified a double positive patient, the first thing you should do is stop. This would be a good time to review the guideline and prepare your crew before you arrive on scene. In general, these patients will not be critically ill, and the medical care that you are able to provide will be very minimal, so there's no rush to arrive on scene quickly. You should immediately notify your agency's chain of command as well as MRCC. For all agencies under the medical direction of Regions EMS, unless the patient's condition requires time-sensitive interventions, you will need to speak with a Regions Hospital infectious disease physician from the scene prior to transport. MRCC will coordinate this, so it is important to notify the operator as soon as possible, even while you're en route to the scene. This also means that you'll most likely remain on scene for an extended period of time. So again, slow down. There's no reason to rush. The second principle we discussed previously is to minimize the exposure risks. There are several ways that you can protect yourself. First of all, it's important to limit the number of personnel that have exposure to the patient. First responders and law enforcement do not need to approach the patient in most situations. The transporting crew should identify a driver who should not have any patient contact and should not enter the residence. This will help keep the front of the ambulance clean, and then this person can also assist with radio and phone communications to avoid contaminating your equipment. Many patients will be ambulatory and may only require one EMS provider to perform the assessment and assist them to the ambulance. Although more providers can suit up in appropriate PPE, you should limit the actual exposure to the minimum personnel necessary to safely provide care. Once the roles have been assigned, appropriate PPE should be donned utilizing the buddy system to double check to make sure that there are no exposed areas of skin. A link to the current CDC recommendations will be maintained on the Regions EMS Facebook page. The current recommendations as of today for PPE include the following. Below the head, providers should wear a Tyvek-style suit without an integrated hood, boot covers which extend at least to the mid-calf, and 2 pairs of long-cuffed gloves. You should cut thumb holes into the Tyvek suit to keep the wrist cuff over the inner gloves. For the head and neck, there should be no skin exposed. You have 2 options. A hooded PAPR would be adequate, assuming the hood covers the neck and the shoulders. The second option would be to use a single-use disposable surgical hood, which covers the head and the shoulders. This should be worn with either a full-face APR respirator or an N95 mask with a single-use full-face splash shield. All of the providers should be appropriately trained and fit tested on a regular basis according to the OSHA respiratory protection standard before using the recommended respiratory protection devices. Although we don't yet have access to a regional Ebola transportation unit, if there is an alternate form of transportation available for the patient, this should be considered, especially if there are family members available who have already been in close contact with the patient. Some agencies have discussed stripping down a reserve ambulance to use for high-risk transports, and this would be appropriate as well to minimize the equipment exposures. Regardless of your transport method, you should prepare the patient compartment according to your agency protocols. There are really no national standard recommendations for this, and several EMS agencies, such as Grady EMS in Atlanta, and then some of the Omaha EMS units that have been transporting some infected patients, have some best practices produced, but there are really no governmental recommendations for this. However, this might include removing any unnecessary equipment, such as extra monitors, medical bags, disposable items, and placing an impermeable barrier over the stretcher to cocoon the patient and limit the risk of contamination of your ambulance with infected body fluids. Now at this point, provider roles have been assigned, PPE has been donned, the transport unit has been prepared, and MRCC has been notified. Now, as you would with a hazmat incident, you should now pause and review the situation with your crew prior to approaching the patient to make sure everyone is on the same page. Once you are with the patient, use common sense while assessing and providing medical interventions. A visual assessment may be all that is necessary. If the patient is awake, coherent, and ambulatory, it may not be necessary to contaminate your equipment by checking a blood pressure, doing a 3-lead EKG, or checking an oxygen saturation, unless you feel that it might change your treatment considerations. And likewise, any intervention should be considered against the risk of body fluid exposure, such as starting an IV, administering a nebulized medication, or providing other treatments outside of basic oxygen via a face mask. Generally speaking, you will not likely need to provide any treatments for most patients. One consideration is that intravenous Zofran can be given orally. This might be a reasonable consideration for patients who have been vomiting. If possible, consider placing a surgical mask or a non-rebreather oxygen mask on the patient to further limit your risk of exposure to body fluids. At this point now, the next step would be to consult with the region's infectious disease expert to further clarify the risk factors. You should be in contact with MRCC by phone throughout this process, and the operator will connect you with the on-call physician. This will most likely be communicated through your driver to avoid contaminating your phone or your radio. Unless the patient is critically ill, you should remain on scene until the infectious disease consultant clears you for transport. If it is determined that the patient is high risk, advise all close household contacts to remain at home and avoid going to the hospital. Obtain names and a contact number for follow-up, but ultimately you have no authority to enforce a quarantine, and we don't believe at this stage it would be appropriate to involve law enforcement. If the patient does ultimately test positive for Ebola, the State Department of Health and the County Public Health Office will follow up with these close contacts and monitor them for signs of infection. Now, as of today, the Minnesota Department of Health has designated 4 hospitals as Ebola treatment facilities. In the metro area, these would include Unity Hospital in Fridley and Fairview Riverside Hospital in Minneapolis. There has been some confusion, and what we know today is that these designations are only for patients who have tested positive for Ebola at another hospital and are being transferred to one of these designated hospitals for ongoing treatment. As a result, this doesn't apply to EMS transports. So today, we don't currently have an EMS specialized destination plan for suspected Ebola patients. You should transport the patient to the closest appropriate facility as you would any other medical condition, considering the patient's preference, geographic distance to the hospital, and the condition of the patient. Make sure that MRCC is involved in your decision in order to provide adequate pre-notification to the receiving facility. Now, when you arrive at the destination hospital, remain in contact with MRCC and stage at the designated area outside of the emergency room. You should not enter the facility unless you are specifically instructed to. Most likely, a hospital staff member will come out and assume the care of your patient and take a report from you in your ambulance. Now, once you have turned over the care of your patient, you must now doff your PPE and disinfect your ambulance and all of your equipment. This should not be taken lightly, as there is still a very high risk to cross-contamination during the doffing process. This is an area that we don't fully have answers yet, but ideally, someone from the hospital would be available to supervise and assist with doffing your PPE. The CDC has recommendations on safely doffing, which you should review and be familiar with. A current link will be posted on the Regions EMS Facebook page. Your ambulance and your equipment should be disinfected using standard hospital-grade disinfectants. After donning clean PPE, you should again take adequate precautions to protect yourself against further exposure to these contaminated body fluids while you are cleaning your equipment. After disinfecting your ambulance, you'll need to doff again using similar precautions as before. Any waste generated during this entire process should be placed in a red biohazard bag and disposed of properly. This waste is considered a Category A infectious substance by the Department of Transportation and is much more tightly regulated than the standard Category B medical waste. Now, if a patient is tested for Ebola, the test will be conducted at a specialized lab run by the Department of Health. In the Twin Cities metro area, the screening test could take up to 8 hours or longer. During this time, although you would technically not be contagious even if you had been exposed, it would be prudent to quarantine at the hospital until the test results are available, and then we can make a more informed decision as far as what your disposition will be. We're working with our local hospitals to determine how this quarantine can be arranged at each facility. Your agency's chain of command and Regions EMS are available to assist as needed in these situations. Once the test results are available, the Department of Health will provide further guidance as needed in coordination with the receiving hospital. Couple other caveats. If you should encounter a patient in cardiac arrest who has recently traveled to an endemic country and has had viral symptoms, the risk of body fluid exposure to EMS providers is extremely high and probably not worth the risk of attempting resuscitation efforts. This is consistent with EMS practices nationwide with the current outbreak. Again, I cannot emphasize enough the need to slow down and be very intentional with each step in the care of a suspected Ebola patient. This guideline is really less about patient care and more about protecting yourself and your crew from unnecessary exposure. Regions EMS is actively involved in the metro area regional preparations, and we will continue to clarify any questions that come up and provide you with the relevant information as it is available. Despite all of the media exposure and discussions that are occurring regarding Ebola, it is very important to keep things in perspective. Despite the widespread disease in West Africa, there have only been a handful of confirmed cases in the United States, all of whom were providing direct medical care to highly infectious Ebola patients. It is unlikely that we will actually see a confirmed case in the Twin Cities, let alone transport an infected patient by EMS. Because of this, we would like to encourage you to use common sense and reliable sources such as the CDC or the World Health Organization when discussing Ebola with friends, family, and coworkers. And we at Regions EMS are always available to answer any other questions you might have as well. The principles we are emphasizing here are applicable to any hazardous material, chemical exposure, biohazard, or significant infectious disease exposure incident. This guideline can be generalized for any high-risk incident, and as such, it should be periodically reviewed with your crews to reinforce the need for appropriate personal protection anytime you go en route to a call.